we're really excited about this guide. It's a financial guide for rural health leaders during COVID and post-COVID. So I'm going to start out, and before I introduce our speaker today, I want to tell you a little bit of background on this. We had been hearing, as a result of the pandemic, that our hospitals were basically experiencing a number of different problems or issues. One, obviously, is they had lower volumes and lower revenue in the hospitals accordingly. So as they focused their attention and their care on COVID patients, other types of care basically was put off, or just basically they weren't able to provide, especially those that had a significant volume of COVID patients. So the lower volumes was part of it. But when you looked at their financial numbers, it didn't really look like there were any financial difficulty, because they had a significantly high cash on hand. And the cash on hand wasn't a problem, because there was a variety of different sources of funding coming in from the federal government, from the states. So there was in very many cases, a very large figure related to cash on hand. But given that large figure, there was a lot of uncertainty about what are our obligations to give this back if we don't spend it. So how much of it is really ours, and how much of it are we going to have to pay back, et cetera. So that was a problem as well. And we also really know that rural hospitals and clinics are probably going to come out on the back end of this, basically, we hope financially healthy. But rather than just count on that, we felt that it was probably very timely to look at strategies they might use, both to make sure that the financial numbers were sound and that they would be financially sound in the back end of this, but also to look at how they might recapture some of that revenue, things they might do to prepare themselves for the future. In another one of our programs where we work with rural hospitals in the Mississippi Delta, we recently had a keynote speaker, Craig Dio, who basically is one of the heads of a consulting group, and the Studer Group, and he basically challenged rural hospitals in his presentation not to come back as normal, but to come back as better, come back as new in that regard. And consequently, we wanted to provide some suggestions here also in terms of kind of how we move forward here. And I should mention that the National Rural Health Resource Center, with funding from the Federal Office of Rural Health Policy, then put about getting to work on producing a manual that would provide guidance for our rural hospitals and rural clinics. And as we looked at the various options as who might do this sort of a guide, we looked to actually Ralph Llewellyn, and Ralph is the partner in charge of critical access hospitals at Eide Bailly. We have worked with Ralph for years and years. He has an almost unique ability to take complex financial information and make it understandable. And I know that every time I hear Ralph, and this is going to be what, at least 50 times on financial subjects, I always learn something. And we also felt that if we were going to put a guide together, it really needed to be something that was relatively simple, that could be of use to both our flex coordinators and our state offices of rural health, but also the hospitals themselves in terms of these suggestions. And so Ralph has been a constant kind of presence within Task, as you folks know. We use Ralph and his associate Brian Birch in our workshops. We basically use them to do a lot of education for us and et cetera. We have other consulting groups that we use as well, but I'm going to bet we probably use Ralph more than any other single individual. And for that, I'm personally, and I know Task is personally very grateful. So with that kind of an introduction, I am going to do the first couple slides here, and then I'm going to turn things over to Ralph. This is just our National Rural Health Resource Center slide with our 5 focus areas: transition to value and population health, collaboration and partnerships, performance improvement, health information technology, and workforce. And with that, let's turn things over to Ralph.
All right. Well, thanks, Terry. Greatly appreciate the introduction and the kind words. So glad to be able to present the financial guide for rural healthcare leader during COVID and post-COVID. Definitely a lot of things going on. So let's just dig into the information. Here you got some information on myself. I was the one that worked on the authoring of this. Also want to make sure I reach out and give credit to Brian Birch, who Terry alluded to. Brian did a lot of the reviewing and second guessing and challenging the thoughts and the input and everything. So I want to make sure Brian gets some credit for that also. So with that, let's get into the guide itself and the agenda. I'm going to do an introduction to the guide. Then I'm going to walk through a little bit about the anticipated impacts of the financial indicators. We'll talk about the indicators a little bit, each one. And then we'll talk what I think is the important part of all of this is that when you know what might be going on with the indicators, what are the strategies that people can use to not just improve the indicators, but just the financial condition or the overall condition of the organization. Kind of that coming back better comment that Terry just brought up. You know, how do you come back out of this better than what we went into this, if at all possible? So let's talk about the introduction to the guide itself. You know, the overall purpose, let's talk about the user group. I think Terry did a nice job of talking about using it with flex individuals, state offices of rural health, the critical access hospital and rural health clinic leaders, those people that, you know, are on the ground in fighting that battle. I also look at this as a great tool for consultants such as myself, other consultants to look at it and look at strategies. Volunteers in the community that are helping these organizations, basically anybody who's trying to help our rural providers navigate these really challenging times that are different than the 30 years that I've been in healthcare. The design of how it was set up, as Terry said, trying to make it as non-technical as possible. You know, this industry is complex and the finances are more complex than any other industry I've ever dealt with, and I've been in a few others. Fortunately, we can break things down oftentimes into some basic concepts. And that's kind of what we'll talk about is some basic concepts and thoughts that people can take and run with that. We'll provide some guidance on the impact on the indicators, what we might expect to see. Terry kind of already gave a little alluding to what you may see in days cash on hand, because there's tons of it in some organizations, but what does that really mean? And then strategies, that'll be that last piece, really digging into the strategies. The layout starts out with the purpose, has the executive summary. Executive summary, those are always the challenges, I think, as to how much time and you spend on those and how much content you have in there. We could have almost done 5 or 10 pages just on summary, I think. But it's about a 3-page summary, walking through kind of the high points that you can take as a quick read. But you're definitely going to want to read through all of the other components, the introduction, the financial indicators, the strategies, and then finally an appendix, which I'll give a lot of credit to the center. They really pulled a lot of that together with some resources that are available from things that they've created in the past, things they found, and other things to assist. So we will start really talking about those major financial indicators and the impacts. So what were the major impacts? Terry already kind of alluded a little bit to this about the lower patient volumes. Well, then we had the lower volumes because people were staying home, places were being shut down. We had this lower revenues, which I remember the first calls in March last year, we were getting calls about people wondering how they were going to stay open, because they didn't just have they didn't have days cash on hand. They had more like minutes. And so now they were struggling with how are we going to handle this, because we're not prepared. And then we had this other side, all these infusions of cash. And I will give the government a ton of credit, you know, CMS and HRSA and all these, of how quick they got money out. Some of those early promises of how fast we would have money, many of us laughed because we'd never seen anything happen that fast from a governmental agency, and they proved themselves to be accurate. Those monies came out really, really fast. And there's a lot of confusion, a lot of things with those dollars that came out, but at least the dollars and cents got into the hands. The other things that we found then is obviously just the increased expenditures. And we'll talk about a couple of areas and how it's going to impact a couple of the indicators. You know, you think about supplies, and then the big one that we've been hearing about more recently is just the salaries. You know, how much people are having to compensate people to find the workers to keep doing the work. And with all that, we get new challenges. You know, we have to develop a new understanding of how it's going to impact the indicators. And then we got to define and we have that necessity to initiate new strategies, things that might be a little different than the past, or maybe there are things we should have done in the past, but haven't. But now we're getting forced into a corner, and we really need to look at them. So let's start with the indicators. The 11 indicators. The 11 indicators, they come from the Small Hospital and Clinic Finance 101 manual, another document and resource that came from the center. I was fortunate enough to sit in the first summit that Terry led. Oh, geez, it's about 9-10 years ago now, when we came up with these indicators, and it was a group of consultants such as myself, academia, providers. We had a nice mix in there. And what I really find interesting is that, you know, 9-10 years later, this has really become the financial indicator Bible in the industry. I can go anywhere in the country and talk about these indicators. These are the indicators that people understand. If I say the top 10, top 11 indicators, they know what document we're talking about. And so we've got a nice set of indicators that people follow. Now we just got to look at each one and talk about what's going to happen or what could happen within those. So we're going to talk by each indicator, the expected impacts, what we should see as people start reporting it data through either flex monitoring team or other things, you know, for the 2020 and 2021. We'll talk about what we expect those indicators might do, as far as will they move up, will they move down, get better, get worse. And then we'll talk about some indicator specific strategies. And when we're done with that, we'll go into strategies that are probably things that'll hit multiple indicators. So let's start with days in accounts receivable. So this one here is days in gross and net, because they tend to follow each other. So a couple of things that we're going to see here. We're going to see and have been seeing great variation, because there's two factors that can be playing, and it depends on how the facility has reacted to it. There are going to be some things that are going to push those days up, and there's some things that may actually push those days downward. And so when we think about unemployment, as unemployment increased, anytime unemployment increased, you should expect there's going to be slower payment coming in. So your days are going to start to increase. Increased levels of uninsured. Now when things start going from insurance to a self-pay, you've got that other slowdown in the payment. And then you just have this overall financial insecurity that people had. You know, even if they had cash today, they weren't sure if they have cash later, so they're just slower on handing it out and trying to keep their cash flow in case there's more emergency down the road that they may not be quite ready for. On the flip side, we have these forces that could drive it down. And we saw some providers, especially those that didn't furlough anything, where they basically used that time to catch up on some of their past sins in their AR, catching up on all the dirty stuff, the hard things to get cleaned up. So while they weren't adding as much new revenue in, they were cleaning out a lot of challenges and fixing some processes and things like that. So where they're going to end up is going to depend on how much they struggled with unemployment, increased in uninsured, as well as how much they took advantage of the time, the downtime, if they had the capability, the staff, to try to catch up. So a couple of things that we're recommending here in the strategy. You know, we really want people, if they've fallen back behind because of the unemployment and the insurance, uninsured and things like that, they really need to get back to those historical levels. And the reason being is that the cash flow needs of the organization long-term aren't going to change. They're going to continue to need cash, and this is where the cash comes in. And the other strategy is that if they were an organization that took advantage of that time to catch up, the strategy there is what do you change in your processes to keep you from getting back to having the problems you had in the past? So are they making the changes in processes, follow up, and all of that there so that they don't slowly creep back to a problem of having problem AR levels that tend to be the things that drive the AR balances up the most. Days cash on hand, you know, as Terry said, a large amount of cash coming in, you know, and there's all kinds of funds that were coming in. Some of them are like the advanced accelerated payments. Those are payments that we know have to go back at some point. So they're not even tied to an expenditure. And then you got the PPP and the PRF, and you got all kinds of other initials, you know, the ERCs, and you got all those things. A lot of these were upfront infusions. So all of a sudden they went from having minutes of cash on hands to sometimes having over a month, 2 months, 3 months cash on hand, which could give you some false security because things feel good right now. And so this large influx now, but there's going to be needs for that after, down the road. They're either going to have to spend the money and document it, or it's going to be lost revenues, which meant you still had other expenses coming in and you weren't able to pay for them with normal funds. The biggest piece we believe you need to do in this area from a strategy perspective is try to figure out how much of that amount of days of cash on hand is already earmarked. So let's say you've got, you know, you've historically ran around 20 days of, or yeah, 40 days, let's say, of cash on hand. And now all of a sudden you're at 200. 200 sounds really, really good. Well, once you start having to earmark all of that out, if you find out at the back end you're down at 0, you've got a problem. It feels good today, but we got to start figuring out, where do we anticipate the expenditures or uses of these funds or repayments are going to be, so that we know what we're really sitting with. How much of it's really ours in the long run versus how much of it's kind of more of a borrowed until it has to be used methodology. So that's going to be the strategy that providers are going to want to look at on days cash on hand. Total margin. Total margin, this one's going to be interesting from the aspect that while you're getting a lot of cash, it doesn't mean you got a lot of revenue. So this gets into a lot of detail. We could spend hours just talking about the AICPA and all the rules of recognizing revenue and such. But just because you got the money, if you haven't earned the retention of it, so you haven't used it for its purpose, it's basically a liability on your books. It's not an income yet. It's not an income stream. So we could have facilities with a lot of cash on hand, but because revenues were down and they haven't met all the criteria to discharge the repayment of that, they may not have recognized the revenues. So we believe we're going to see some large fluctuations. Those that have recognized the revenue may not look as tough as those that have not been able to yet. Now, on the flip side, a year later, they might get to recognize, but the other ones have already recognized theirs. The numbers may start to flip back and forth. So here, really the strategy is one, we still have to figure out how we manage to our original old-time benchmarks, because we still have to have cash flow to run the business long term. And so what you want to start looking at is, what would that have looked like if we had pulled out the anomalies? We pulled out some of those infusions of cash, and we changed, looked at some of those changes in our investment income, because investment income for a lot of facilities went way down, and figure out where are we at there. So this is where we're not going to be able to measure this nationally at what would have happened with all the cash infusions, but individual facilities are highly recommend to go back, look at this from an adjusted total margin, taking out some of those anomalies. And the goal is to know where you're at and how are you going to get back to those numbers that you knew you had to be at in the past. Operating margin is even going to probably have greater fluctuations. And the reason being is that they're going to have the same issues going on that you have with the total margin as to when you recognize the revenue and when you had the expenses and all of that. The only problem is that for some entities, that recognition of the revenue isn't at the operating line. For some facilities, they get to recognize it based on FASB or GASB rules in the operating line. Others have to recognize it in the total margin line. And so we're going to have some variations here that are not going to be easily identified by just looking at one facility to the next. We're going to need to know, are they governmental, are they not? Even within governmental, it can depend on what their accounting policies are and such. So there's going to be some great variation. The strategy, though, is the same basically as what we talk about in the total margin. And that is really going back to that, what would it look like if we take out the anomalies? And the goal again is how do we get ourselves so that we're managing ourselves back to where we needed to be in the past to perform, to be able to succeed. Because ultimately, when we come out of all of COVID, the benchmarks that we've historically looked at are probably going to have to look very similar. They may even need to look better, but they're going to have to look very similar. And some of these anomalies, when you get a huge revenue stream in one year and not in the next and things like that, again, they may give false hope. They may also give false doom. We really need to figure out what is really there so people are able to focus on what is important. What is the important piece of all of this? Current ratio. Current ratio is an interesting one because when you think about the current ratio, it's the comparison of current assets to current liabilities. Well, as these influx of funds have come in, when they initially come in, they're all being put on the books as liabilities because they're still due back, they're still payable back to an entity. So we're basically increasing them at the same rate. So it's basically a 1.0 increase. So what that means is that we would anticipate that if a facility had, let's say, a 2.0 current ratio in the past, adding $1 of asset to $1 of liability is basically going to continue to decrease that until it gets closer to 1. On the flip side, if they had a current ratio that was below 1, as you add all of those dollars in at a 1-to-1 ratio, it's probably going to push that back up. And so really, again, here's just another area where we recommend considering, an adjusted calculation, pulling out that extra asset and liability that is associated with those funds until such point in time that they go away, so we can better understand how are we doing once that goes away. Are we prepared to come out of this on the back end in a good shape? So at least we understand. If it doesn't look like we're going to be in a good shape, that's going to even change some of our strategies. Now we know we got to act now rather than waiting until the money starts going away, and by the time we figure out we have a problem, it's too late. Debt service coverage. When we think about debt service coverage, I would say the thing that we think about here is we really don't expect to see a whole lot of new debt activity in 2020 and 2021. I mean, there are some people that are trying to do some projects, but even then they're being delayed because of the inability to get materials, contractors, all of that kind of stuff. So the debt side of it's probably not going to change a whole lot. What's going to change is their ability to pay for it through total margin. So the fluctuations we're going to see are going to be around the total margin, not so much the debt numbers. So the thing that people have to watch here is that a lot of times when you have debt out there, you have debt covenants, and these are covenants that say you have to maintain a debt service coverage of X, a current ratio of X, things like that. And if you don't, they have the ability to force you to have to do certain things at the management level, hire operational consultants, things like that are can add costs. There are obviously some benefits to it too. And the strategy here from our perspective is you really want providers to be watching those debt covenants. And if they think there's going to be an issue and it's due to COVID and things like that, they start having those conversations with the lenders, as well as starting taking immediate action. So at the end of the day, hopefully they're able to avoid all of those extra steps that come through if you trip a debt covenant. Those are painful. And so that's going to be something that I don't hear a lot of people talking about. It's one of the areas I've got a lot of concern with some of my providers that are on the edge. So it's definitely something that we want to be watching for them. Salaries to net patient revenue. You know, when you think about what's happened, we know there's been higher salaries because we've heard, you know, people are paying higher wages, even if they did furloughs or, you know, just the increases in bonuses and things to keep people coming in, all of those things, you know, loyalty bonuses, all that. So we're going to see higher total wages, we believe, or total cost to staff anyway, higher hourly wages. The interesting piece is that not all of it's going to be salary. So we may actually see a significant reduction in salary for a lot of facilities, but it's going to go into contract labor. And where this statistics come from is from the cost report, which looks at the salaries that are reported on the cost report. There isn't a way to get contract labor on the cost report. It's been one of the potential weaknesses of this indicator over time. And so what you may see is this huge reduction in salaries. It'll make them look like they're doing great from a salary to net patient revenue, but they outspent it on their increases in contract. And so really, when we think about this one, probably not as beneficial to look at this one in the long run at the surface. If I was in the provider's shoe, the strategy I would be using would be going back and looking at, well, how much did I spend on staffing in the past between salary and contract? And how am I doing with that today? And starting to look at that to see if I'm managing that as well as I possibly can. And it's still going to be a challenge because we've heard the high rates that some have had to pay for contract staff. This one's going to be a tough one to get out of in the short run, but they're going to need to be working on strategies as they consider looking forward into the future. The payer mix percentage. You know, this one is interesting because I think you've got some different things pulling. It could go up or could go down depending on where you're at. Medicare patients are older, obviously more susceptible to COVID. We saw that early on. A lot of the people that we saw in the hospitals, in the ICUs and everything were of elderly status. And so that would tend to tell you that, well, maybe we're going to see this push upward of Medicare utilization. We know payer mix, the lower Medicare, the better historically over time. But you look at what's happened to COVID in the kind of the second half of the PHE, where it's moved it's not just the elderly, it's the young, it's the children even now. We're seeing birthing age moms. You know, we've got a lot of changes there. And then we've got this issue that younger patients may have been more effective at avoiding care for a while, pushing things out, things that weren't significant that they had to deal with. So all of those, so we're not quite sure exactly where that's going to go, and that could be very market specific, depending on the individual market. So really, the strategy here is throughout all of this, and this kind of goes into even when we talk about a little later on some things that are near and dear to my heart, like out migration and things like that. You know, continue to focus on maximizing access and volumes and access to all ages. And the more you drive this, what you really want to do over time, a lot of that out migration is commercial market. That's the profit market. You know, that's where you really want to continue to push that. Average age of plant. You know, this is an indicator that doesn't typically move much, at least at the nationally level each year. Even within a facility, it doesn't move much. If a facility doesn't do any new equipment in a year, their average age of plant will move up on average 1 year, just because their plant got 1 year older. So to make it move significantly up, it takes a little bit of time, multiple years to do that. Really, when you see that number change is when facilities moved up for a long time period, then they do a major renovation of the hospital, rebuild, things like that. Now all of a sudden it drops way down, and then over time it continues to creep back up. So With zero investment, again, you wouldn't anticipate it to do much except maybe move up about 1. I think what we're going to be looking at here is what's going to happen in the years going forward, because we know providers have looked at the need to enhance some capital, do some rebuilds, some remodels, things like that to better take care of patients in a PHE type atmosphere. And so with that, I would envision the piece there is trying to make sure, how do you balance all of the new needs with your ability? And that's going to be, right now it's going to look like, oh, I got a lot of cash, I can do that. But that cash might already have another home. So there's going to be a lot of balancing going on with that. And then the last one, long-term debt to capitalization. Again, anticipate this year to be probably fairly stable. Again, not a whole lot of new debt going out there. Capitalization probably hasn't changed a whole lot. It's going to be going into 2021 as people are looking to do projects and things like that. So that's where we're going to really watch that. And the strategy here is, anticipate the future investments. We're going to see changes in the nature of investments. They may need to make a little bit more investment for a couple of years to get caught up on things that crept up in all of this. There's definitely a lot of challenges. People didn't anticipate things that they might have to deal with at some point in time. So the hard part is with the newly identified needs, it's still going to have to fit within their abilities. And some people are going to have a lot more needs than abilities. So there's going to be some continued management and monitoring there. All right. With that, that kind of moves us next into the strategies. There's 9 strategies really on how do we try to improve the overall performance of the organization, not just the indicator, but the whole organization. And each one of these strategies could ultimately, and most usually, will help improve more than just one area. So community health needs assessment, really the strategy here that everybody should be doing is going back, reviewing their community health needs assessment for completeness, make sure that they look at enhancing their processes. And really what we're looking at there is, I think, my opinion from the community health needs assessments I've looked at overall is that they don't dig deep enough. We don't get enough information to understand about our patients and figure out the things that we should want to know so that we can better set up strategies to drive volumes, address out-migration, which I'll talk about again later, and a couple of other things. So really the action items here, as they look at their community health needs assessment, 1, add market share assessments and projected future demographic service line trends. Add that so they better understand what's the future going to look like. Don't just look at what's going on today. Look at survey tools. And this is kind of surveying the patients, the potential patients, the ones that aren't your patients, trying to find out when people don't use you, why don't they use you? Those are the things that, people need to, come back better. Back to Terry's comment. How do we come back better? We better understand our patients. We better understand why they go somewhere else. We better understand all of these things. And then use the community health needs assessment as the basis to how you improve payer mix and marketing efforts, because that's going to tell us where we should be driving our stuff. And oftentimes I'll find that the marketing efforts don't tie to the community health needs assessment. They may not tie to the strategic plan either. That's a weakness. And then finally, if they're not required to do a community health needs assessment because they're a governmental entity and not required, we highly recommend they do that anyway. There is so much to be learned. I know it's a governmental requirement that they have to do, and people don't like, mandates of having to do these things. But this one, if it's done right, truly does provide some real benefit to the organization. Strategic planning. Really, when you think about it, if they did a strategic plan in January of 2020, it's already outdated. You really need to step back and relook at everything that's changed. So update, the current plan to make sure it's relevant. So the action item there is really start with data. A lot of that data is some of the stuff we talk about getting in the community health needs assessment. It's talking about looking at market and looking at demographics, age, income, service line anticipated changes using predictive analytics and things like that to understand what they should be building, what they should be looking to do in the future. Reviewing and updating that plan. The last part of this is the piece that's oftentimes missing in strategic plans. That's the assignment of responsibility and timelines. And then it's the accountability of the monthly reporting. How often have we heard stories of people saying, yep, it's time to do the strategic plan. Let's go dust it off the shelf, because it hasn't been looked at since the last time we did the strategic plan. We got to get past that. Strategic plans are extremely powerful, but only if somebody does something with them. And that's the big piece. And we're seeing a lot of activity in the area of strategic planning right now. Assessing operational efficiency and effectiveness. Really here, a couple of the things that we're thinking of from a strategy perspective is how do we take advantage of those best practices that came up during COVID? Some entities had to become extremely nimble and efficient by learning how to do a lot of tasks with less people, less resources. And what you want to do is step back and go, are there things that we had that we learned that we could continue to do in the long run? They weren't easy at first, but now that they're there, they work. Rather than just saying, oh, now we can go back to the old. We can staff back up to what we had. We can go back to operate the way we used to. All of that. Take advantage of the things that you worked hard and already learned in the organization. The other part is it's a great time to do a comprehensive review of staffing. Every facility I've ever been in says they don't have enough staff. I would say every organization I've ever been in has opportunity to work with less, but they have to understand their operations and their processes. A lot of times they're working on broken processes, and they're working really, 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 really hard. It's kind of like if Terry said, hey, come see me in Duluth. And he said, how long will it take you to drive from Fargo to Duluth? And I said, oh, 5 hours. And he said, no. You have to go through Seattle. Well, if I went through Seattle, there's no way I could do that efficiently. And what we have in our organizations is we have people all day long that, because of the way our processes are built, we're telling them to drive from Fargo, North Dakota to Duluth, Minnesota, but you have to go through Seattle. It doesn't matter how hard they work. They're just spinning. So identify the operational efficiencies, determine what things could be done permanent in there, and then really doing a comprehensive review of staffing and operations and looking at those processes. And it's amazing what can be found when you dig under the hood that way. Exploration of population health and wellness opportunities. This is really looking at population health. We oftentimes just think about ACOs and things like that. That's part of it, but we're looking at even just the services that are surrounding population health. Excuse me. And when you think about that, think about wellness services and preventive services and all those things. So the actions here is, we want to compile a list of all those things that we could be doing. ACOs, wellness services, all those things that Medicare will pay for now. And most of them, no deductibles, no copays, all these preventative things that we begged the industry for years to give us. Now they're there. And we have providers that aren't taking advantage and providing that benefit to the patients. And we think about it from a Medicare perspective, that Medicare patient has already paid the bill in their premiums that they had to pay for years into the fund Medicare. Now they have these things that they could be getting for free with little to no deductible and copay, and they don't even know they can get it. And it's good for them. So identify the opportunities, the gaps, the things to grow, do financial feasibility there, and then really develop a plan around how are you going to use that to increase utilization of existing services as well as new and wellness and preventative services. And if you do this really, really well, it's a great way to start capturing out migration, start grabbing a greater portion of that market share. And then reinventing themselves. And this reinventing is more of a, stepping back and looking at, what's access mean, and make sure that the strategies we have really are promoting access and promoting increased volumes. Some people think access means I'm open from 8 to 5. Well, for the people that work, that's not necessarily access. So it's looking at things like hours. So that gets into this action. Look at your hours of operation, address opportunities to improve access and volumes by adjusting hours. And when I say it by doing this, some people think I mean they got to be open 24/7. That's not at all what you're talking about. Sometimes you're talking about little tweaks that just add the ability for people in the population to use you versus having to drive somewhere else to use somebody else. And then with all of that, you start looking at a comprehensive marketing strategy, making sure that it's in alignment with, your hours, your community health needs assessment, and everything, so you can build awareness, loyalty, and ultimately patient volumes from people that you may not be serving already, or people that you could be providing better service to. Service line analysis, really the strategy here is just looking at your service lines, the ones that are doing well and those are not. It used to be years ago, we could have a lot of loss leaders because we had profit centers. The payer mixes and the things that have been going on have really whittled that ability down, but sometimes we have a hard time letting go of things that maybe aren't really providing the impact that they need to in the organization and into the community. So really looking at all the service lines that are struggling financially, performing a deeper analysis to figure out which ones can be improved, which ones cannot be improved. Those that can be improved, working on plans. Those that can't, then you step back and you look at, okay, is this something that we're doing through mission only? Or is it something that maybe we need to unload, find somebody else that can better take care of it, still provide access to the care? I'm always careful to add that piece to it, because it's not how do I eliminate the service and access, it's how do I then find somebody else who can better do it, because maybe they have better volumes, better something else. Telehealth, think about everything that's happened in telehealth in the last year and a half. Really here is the strategy is completing an analysis of what are you doing in telehealth and in all of these teletype services versus what you could be doing. So doing a complete inventory, looking at what you are offering versus what could be offered. For those that you don't offer, looking at doing some financial feasibility. And, I think sometimes with telehealth, people get scared of it because that individual telehealth service may not make a lot of money on it, or it may not even break even on the telehealth, but it's all the ancillaries and all the other things that ride behind it that really can help drive it. So you got to step back and look at it a little bigger, and then compiling and completing an implementation plan. How do you take advantage of this opportunity to use telehealth to your advantage rather than the disadvantage? Too many rural providers, I think, look at telehealth as just being a threat. It can also be an opportunity. Out-migration. Here, the identification and implementation of strategies to decrease out-migration. A lot of times when we talk to providers initially and talk about what kind of market share they get, they tend to have a pretty high thought on how much market share they're capturing. But when you start digging into the data using either statewide available data or CMS data or other data sources, you start to find that there is a significant amount of volume that is leaving the community that no one's aware of, or no one wants to at least admit that they are aware of. And so you heard me talk about in the community health needs assessment, trying to figure those things out. But at a minimum, if you're just going to go after this strategy, it's doing a comprehensive market share assessment and really identifying where are people going. And when they are going somewhere else, figuring out why. What's the root cause? Is it a service problem? Is it that we don't do the service? And here's one where you sometimes just have to really look and do a lot of soul searching and admit that maybe you're not doing something as well as you could. And how do you change that? How do you change a perception? How do you change a service? How do you improve upon, and then develop a strategy to address that out migration so that you can bring that home? That's sometimes the easiest volume you can find. And then one of my pet peeves is maintaining ongoing education. As soon as times get tough, the first thing that many organizations do, and this is not just healthcare, this is any organization I've ever belonged to in my whole career, is they cut education. And when times are tough, the most important thing you need is smart, educated, on leading edge people. And so the strategy here is really stepping back and making sure that there's a proper mix of education. So proper mix meaning, do you have a proper mix of remote versus live? We've all gotten used to doing remote like this, and these things work for certain things, but there's certain times when you have to get live, because that's where you build your networks. Because unfortunately, when we're all done here, we're not going to go stand in the hallway and talk to each other and and gab about something that we're struggling with or whatever, we miss that piece. So there's got to be a healthy mix. I have some providers that are really pretty much thinking that they can do all their education in the future remote. They're in trouble. It worked in a short run. We had to do it, but there's a balancing act going forward. And it's not just the CEO and the CFO getting the education. It's making sure you're getting it down to all the right levels. Because if there's one thing we found this last year is you need a lot of people to jump on board when things go south. And they all need to understand their pieces in their areas. So definitely a big piece to be looking at there. So that takes us through all of the strategies that we have, and then the resources. And this is an immense amount of information. 5 pages of potential source resources. And it was really nice that they sorted it all out by topic area. So you've got all kinds of different things to look at. Not every piece is going to be applicable to every person, but if you can't find something in there that is of value and use to either yourself or the organizations that we're working with, I'd be surprised. There is just an awful lot of great information in there. A lot of manuals and tools and articles and things like that. I highly encourage you to look into those and make sure you familiarize yourself with as many of those as you can. Obviously, there'd be a lot of reading if you read all 5 pages of them, but there's definitely some good content there. So at the end of the day, the conclusion, the PHE, it's been tough. I mean, I'm a former hospital CFO. I think I was in an easy time compared to what these folks have been going through. I can't imagine what it would be like, even the organization I was in. I do talk to them on a fairly regular basis, 20 some years later. It's just a whole different monster out there. The financial mark, some of it's going to be permanent, some of it's going to be temporary. There's things we're going to be able to dig out of. Some are going to come out better than others, as is the case any year. As we look at the financial indicators here, positive results are not necessarily going to be easy, but there are actions that can be taken. There are steps that are going to be taken, and they're not easy, but management isn't always easy. But they're not also rocket science. They're just things of getting plans put in place, strategies put in place, execution, and accountability. So with that, we've got a couple of minutes left here, I believe, and I can open it up to questions if anybody has any questions.
Hey, Terry. Hey, Ralph. Thanks for the presentation. This guide looks wonderful. My question is just on simple distribution. Are we encouraged to obviously use this in our office, but to send it out to the masses in our state?
Yeah, I'll answer that one, Catherine. We're hoping that our flex programs in our state offices distribute this as widely as possible. I really think, Ralph mentioned every rural hospital should be doing strategic planning right now. I can tell you that our center is going through an extensive strategic planning process because so much has changed in that regard. So I think what Ralph has laid out here is kind of a guidebook and what to be looking at as we're approaching 2022 and beyond. So if you folks could get this information out, it would be greatly appreciated.
I can't tell you how many times in the last 10 years or so now that I have shared the 101 manual. This one's another one. The COVID tool on funding. I mean, there are so many good resources there, and they don't always have every piece of everything that you have to do the step by step, but they are so solid as far as content and giving people the direction of where they need to go.
Jack King here in Montana.
Hey, Jack.
Probably couldn't be a more timely delivery of a resource as we're working on a new model of strategic planning here, most especially for our small, tiny hospitals and their boards. And this will go out to all of our hospitals, but it will also start be included in our strategic planning efforts. So thanks very much. Not a surprise. This this is the quality of the work we always get from you, but it comes at a wonderful time, and it's great to see you. So thanks very much.
Thank you, Jack.
I want to express and appreciate not just to Ralph, but to folks that sometimes, we don't appreciate or we don't express our appreciation. And that's the Federal Office of Rural Health Policy, because in effect, they work with us in terms of choosing topics. We're getting feedback from their program officers, from Tori, from, the leadership, et cetera. And then after we do come up with something, we take a look at it. We try to make it as complete as possible, but then we ship it off to Tori or whoever would be the appropriate FRHP staff person, who in turn looks at it and gives us feedback and improves it in that regard. So we not only appreciate the funding that comes down to us and to all of you in that regard, but also appreciate their involvement in making this guide as good as I think this one really is. So I just wanted to say thank you. I think for Tracy, yeah, and Kristen Ryder and George Pink with the Flex Monitoring team on helping with this as well. Yeah, I didn't mean to neglect them as well. So, we've reached out to our research folks at the North Carolina Rural Health Research Center. And so this has been a joint project. I think we're proud of this document. And again, I want to thank everybody for being on this webinar. And as mentioned, just invite you to let us know whenever we can be of help in any way. Thanks, everyone.